All right, guys, I'm just going to run through the reject analysis portion fairly quickly. There's really minimal that you'll actually have to know for your boards. I just want you to sort of know some of the terminology. Reject analysis is essentially analyzing how many times you reject an image and what it costs the department every time you have to actually reject an image or repeat an image. There are standardized reasons for rejection, and every time you guys go to reject an image, you get a drop-down menu of options, and this is just sort of an example of what those options are. The monitoring tool, it assesses image quality, it optimizes examination protocols, identifies areas that staff may need additional training or education. It can also track patient radiation exposures. There are calculations here. You guys don't need to know these calculations. They were just here so you sort of have an idea of how they calculate their reject analysis rates. Time's an important resource in radiology, as all of you know, right? The time it takes to get the patient down to our department, the time it takes to perform the exam well, while taking into account all of the possible obstacles that you could run into depending on different patient types. We know from scheduling wise that time is important in scheduling the patients in the correct time slots especially for fluoro exams. You've all done fluoro exams where the patient had to wait close to an hour because of scheduling mishaps or whatnots, but time is a huge cost driver in hospitals in general, in patient care. Cost of repeats, it's common to repeat exams, but the exams are usually rejected for poor image quality, motion, something like that. My one recommendation as far as repeats goes is when you're about to take an image, if your gut is telling you this image is not going to come out, I don't feel good about it, I don't think it's going to be good, don't hit the button. Go back in the room, look it back over, move what you need to move to feel more confident in it. Because usually if your gut's telling you it's not going to come out, it's not going to come out, and you're going to have to repeat it anyways. So just take the extra second, feel good about that exposure before you do it, and go with your gut. All right. A RAP team is a repeat analysis program team. It involves a physicist, a QC technologist, and a radiologist. Radiologist feedback. I think radiologist feedback is a critical component to all things radiology. Techs and even image quality sort of feedback is key. They can flag images that sort of need improving on quality. Negative feedback, they can send negative feedback through. They used to do this a lot more in the past, and now I haven't seen it as much, but radiologist acceptance of images can vary. There can be sort of acceptance limits depending on location or radiologist preference. So if you see this graph here of radiographs produced, and this side will be underexposed, middle or A is sort of perfect, and then overexposed. Most of your radiologists' limits, they accept minimal things that are underexposed, but they accept a lot more things that are overexposed than underexposed. So here's sort of a bar, image quality wise, of what they'll accept. Departments may have high standards or low standards for their radiologists, and we've all worked at different locations, and clearly the standards are different at different areas, right? So this is a much tighter acceptance limit bar, which might be us, or our pediatric radiologists might be in this sort of tight limit. This is a very broad acceptance limit between under and overexposed. So it might be at a different site that you see this. But if you have a technologist working with a radiologist with a very broad acceptance limit, they're not going to sort of get the feedback that they need to produce the higher quality images if the radiologist is just reading whatever you give them. Electronic cropping versus reject or repeat. So on this side here, I just have some terminology to start talking about this. Processing is manipulation of your raw data. So when you guys are using the window level to adjust brightness on your screen or adjust the contrast on your screen, that's processing. It's something that happens after exposure. Cropping is something that you as technologists might do, and you're removing a portion of the image, and that's something you do yourself. Electronic masking. It's the electronic collimation or cropping of the digital image that occurs post-processing of the acquired image. It doesn't alter the size of the irradiated field. Shuttering, and I know you guys have seen this before, shuttering is what removes the white borders around the sides of the image. Something to start discussing is that the ASRT states that technologists should not be cropping or masking areas of exposure from the image that are presented for interpretation. If you are seeing your tech or you yourself are cropping off exposed areas quite often, you're actually not doing what you should be doing. Basically, if you've exposed it, you should be sending it. How do you evaluate your image for quality? And I want you guys to really start thinking about this now that you're going to be graduating shortly. I want you to really start evaluating your own images. What do you look for? What's your first go-to? Is all your anatomy included? How's my positioning? Am I accurate? How's my centering? My collimation? Is my marker on? Is it the right marker? Is it in the anatomy? Looking at your exposure index. What did you use for your technical factors? You can look at your spatial resolution or your bony detail. Is there noise? Is it fuzzy? Is it quantum model? Did you not use enough mass? Saturation. Can you see the soft tissue or is it burnt out? Did you overexpose? Is your image distorted at all? Is there magnification? Is there elongation? Is there foreshortening? Was something not lined up, basically? And then you can look at things that could possibly be out of your control. So patient factors, patient size, patient ability, their age, their condition. Are they contracted? Pathology. Are their bones really brittle? Body habitus. Are they massive? Is there tubes and lines that you needed to adjust your centering for? Can you see the tubes and lines if that's what you're looking for? Artifacts. They can be internal, external. Is it something you could move out of the way? And are you getting grid lines? Those were just some examples on how to evaluate your image for quality.